In this video we will discuss about the presentation of common musculoskeletal disorders and their step-by-step physiotherapy management. This is the fourth part of our course. In the previous lectures we discussed about the history of physiotherapy, career opportunities, medical terminologies, basics of electrotherapy, and therapeutic exercises. Links of these videos are mentioned in the description box. Let's come to our topic. Presentation of musculoskeletal disorders. If there is limited active range of motion of a region, but passive movement is possible, the issue may be the muscular. But if both the active and passive range of motion of the region is limited, there may be any joint deformity. Pain occurring on weight bearing, usually a sign of overstraining of the lower extremities, or it usually a sign of osteoarthritis of the lower extremities. Pain that occurs after a patient rests, and the improves with movement, it is usually a sign of osteoarthritis joints, occasionally sprains and strains. Sprain and strains are mostly caused by minor trauma, overuse, force, or stretching. While the osteoarthritis are degenerative changes that occurs with the passage of time. Pain occurring on movement of a joint, and stopping when joint is at rest, usually a sign of acute joint disorder, sometimes a sprain or strain. Pain radiating along the distribution of a nerve, usually suggests the presence of a lesion or nerve impingement. Pain occurring immediately after an injury, usually equated with a fracture, tear of muscle, ligament of other tissue. The problems or disorders that we will discuss in this video are osteoarthritis, rheumatoid arthritis, gout, fibromyalgia, tendinitis, tennis elbow and golfer's elbow, carpal tunnel syndrome and frozen shoulder. Osteoarthritis is the most common form of arthritis. It is a degenerative joint disease. It occurs most frequently in the hands, hips, and knees. In osteoarthritis, the cartilage within a joint begins to break down and the underlying bone begins to change. These changes usually develop slowly and get worse over time. The signs and symptoms of osteoarthritis include pain, stiffness, decreased range of motion, and swelling. Different electrotherapeutic modalities which are commonly employed to alleviate symptoms of osteoarthritis are ultrasound therapy at 0.5 to 5 MHz, transcutaneous electrical nerve stimulation at 2 to 10 Hz, and neuromuscular electrical stimulation at 50 to 100 Hz. Manual therapy techniques for knee osteoarthritis. Muscle energy techniques including post-isometric relaxation, reciprocal inhibition, eccentric contraction, and concentric contraction. Proprioceptive neuromuscular facilitation techniques including hold relax, contract relax, and hold relax with agonist contraction. Passive joint mobilization of tibiofemoral joint and patella. Here is a rough demonstration of tibiofemoral mobilization, including anterior-posterior and posterior-anterior gliding of tibia on femur, anterior-medial gliding of tibia on femur, anterior-lateral gliding of tibia on femur, and patellar mobilization. Exercise recommendations for knee osteoarthritis are quadriceps sets, standing terminal knee extensions, seated leg presses, partial squats, not deep step-ups, flexibility and roam exercises, prone knee bending exercise. Calf stretching, hamstring stretching, and quadriceps stretching, stationary biking, and unloading braces. Taping for knee osteoarthritis. Rheumatoid arthritis, it is an autoimmune and inflammatory disease, which means that immune system attacks healthy cells in the body by mistake, causing pain and swelling in the affected parts of the body. Rheumatoid arthritis mainly attacks the joints, usually many joints at once. Rheumatoid arthritis commonly affects joints in the hands, wrists, and knees. In a joint with rheumatoid arthritis, the lining of the joint becomes inflamed, causing damage to joint tissue. This tissue damage can cause long-lasting or chronic pain, unsteadiness, lack of balance, and deformity, joint misshapens. Features of rheumatoid arthritis include morning stiffness, lasting at least 1 hour before maximal improvement, soft tissue swelling of 3 or more joints observed by a physician, swelling of the proximal interphalangeal, metacarpophalangeal, or wrist joints, symmetrical swelling, rheumatoid nodules, the presence of rheumatoid factor, radiographic erosions, and periarticular osteopenia in hand and wrist joints. Electrotherapy for rheumatoid arthritis. Physiotherapy modalities including cold or hot applications, cold, for acute phase, and heat, for chronic phase and used before exercise, transcutaneous electrical nerve stimulation and hydrotherapy can also be used to relieve pain. Rehabilitative treatments for rheumatoid arthritis, joint protection strategies including, number 1, rest and splinting. Orthosis and splinting prevent the development of deformities and support joints. Number 2, therapy gloves, to control and manage hand pain, to maintain or restore the patient's hand function, or to psychologically help to relax or calm the wearer. Number 3, compression gloves, manage moderate joint swelling and consequently reduce the pain. Number 4, assistive devices and adaptive equipment, arrangements like elevated toilet seats, to facilitate activities of daily living. Number 5, massage therapy, improve flexibility and welfare dimension of depression, anxiety, mood and pain. Therapeutic exercises for rheumatoid arthritis, range of motion exercises. In acute phase, isometric or static exercises to be held for 6 seconds and repeated 5 to 10 times each day. In chronic phase, isotonic exercises, swimming, walking, cycling to minimum 4 repetitions for each joint, in 2 to 3 days, increases the mobility of the joint. Stretching exercises should be avoided in acute cases. Strengthening exercises, use light weights, important for stabilization of the joint and prevention of traumatic injuries. Aerobic condition exercises, improve the muscle endurance and aerobic capacity, continue doing routine daily activities. Gout is a metabolic disorder, however, because the clinical presentation closely resembles arthritis. Gout is also classified as a form of crystal-induced arthritis. During acute exacerbations, the physical therapist should focus on reinforcement of management program and splinting, orthotics, or other assistive devices to protect the affected joints. During intercritical phases, physical therapists may offer assistance with maintenance of range of motion, strength, and function. The physical therapist can also assist the patient in the creation of a suitable exercise routine, and keeping their weight under control. A study published in 2002, in the Journal of Rheumatology found that the use of cryotherapy, to alleviate the pain associated with acute bouts of gout, may be effective. Tennis elbow or lateral epicondylitis. It is a type of tendinitis, causing swelling of the extensor tendons of forearm, that causes pain in the elbow and arm. In occupations requiring repetitive upper extremity activities and particularly those involving computer use, heavy lifting, forceful forearm pronation and supination, and repetitive vibration, lateral epicondylitis is repeatedly seen. Physiotherapy management of tennis elbow. First step is patient education. The first stages of tennis elbow are considered inflammatory. Recovery and treatment will depend on the general health of the body. Smoking, high consumption of processed and fatty food and obesity can delay the recovery. For pain management, electrotherapy modalities including ultrasound, shockwave therapy and TENS can be used. Braces, splints and straps can be used for limited time period. Exercise therapy for tennis elbow. Following exercises can be performed: wrist and elbow range of motion exercises, wrist muscles stretching, forearm pronation and supination exercises, wrist flexion and extension with resistance. Forearm pronation and supination with resistance, wrist radial and ulnar deviation with resistance, wrist extension exercises with any stick in hand, ball squeezing exercises, bicep curls, drawing the sword exercise and cloth wringing etc. Try these stretches for tennis elbow. Instrumental assisted soft tissue mobilization. Mobilization with movement. Other treatment options include Mills mobilization. The commonly used Mills manipulation is a small amplitude high velocity thrust, performed at the end of elbow extension, while the wrist and hand are held flexed. Taping for tennis elbow. Golfer's elbow, also known as medial epicondylitis. The patient usually complains about pain of the elbow, distal to the medial epicondyle of the humerus, with radiation up and down the arm, most common on the ulnar side of the forearm, the wrist and occasionally in the fingers. Local tenderness over the medial epicondyle and the conjoint tendon of the flexor group, without evidence of swelling or erythema, are also characteristics that can occur. Other symptoms are stiffness of the elbow, weakness in the hand and the wrist, and a numbness or tingling feeling in the fingers, mostly ring and little finger. The main goal of the conservative treatment is to relieve pain and reduce inflammation. These two things will help to achieve a proper rehabilitation and later, a return to usual activities. Physiotherapy treatment can be divided into 3 phases. Phase 1, the patient immediately has to stop the offending activities. It's not recommended to stop all activities or sports since that can cause atrophy of the muscles. The therapy starts with PRICE, which stands for prevention or protection, rest, ice, compression, elevation, modalities and medication. The affected elbow should be iced several times a day for about a quarter. This improves the local vasoconstrictive and analgesic effects. As for medication, the patient can take nonsteroidal anti-inflammatory medication. If the patient's condition doesn't improve, a period of night splinting is adequate. This is usually accompanied with a local corticosteroid injection, around the origin of the wrist flexor group. Physical therapy modalities like ultrasound and high-voltage galvanic stimulation shows beneficial effects. Counterforce bracing is recommended for athletes with symptoms of medial epicondylopathy. Phase 2. The first goal of the second phase is to establish full, painless, wrist and elbow range of motion. This is soon followed by stretching and progressive isometric exercises. Elbow exercises can be performed in pain-free range. The short-term analgesic effect of manipulation techniques may allow more vigorous stretching and strengthening exercises, resulting in a better and faster recovery. As the flexibility and the strength of the elbow area return, concentric and eccentric resistive exercises are added to the rehabilitation program. There is an evidence that supports the usage of muscle energy techniques to improve range of motion. These are the demonstration of exercises for golfer elbow. Phase 3. Safe return to activities. Taping for golfer elbow. Fibromyalgia is a syndrome characterized by widespread chronic pain, in addition to several additional comorbidities including pain and stiffness all over the body, fatigue and tiredness, depression and anxiety, sleep problems, problems with thinking, memory, and concentration, headaches, including migraines. The symptoms associated with fibromyalgia may originate from abnormal central nervous system output. There is gold-level evidence that supervised aerobic exercise training has beneficial effects on physical capacity and fibromyalgia symptoms. Strength training may also have benefits on some fibromyalgia symptoms. Relaxation techniques, stretching, manual lymph drainage therapy and connective tissue massage have also been shown good effects. Carpal tunnel syndrome is a cause of functional impairment and chronic wrist pain of the hand. It results from compression of the median nerve as it passes through the carpal tunnel. The carpal tunnel is a narrow passageway surrounded by bones and ligaments on the palm side of hand. When the median nerve is compressed, the symptoms can include numbness, tingling and weakness in the hand and arm. Physiotherapy management of carpal tunnel syndrome. Physical therapists should give advice on modifications of activities in the workplace, ergonomic modifications. Task modification, for example, taking sufficient rest and variation of movements. Electrotherapy for carpal tunnel syndrome. Physiotherapy modalities like TENS, ultrasound, and electromagnetic field therapy have useful effects on hand sensory discomfort. Manual therapy for carpal tunnel syndrome include soft tissue mobilization, mobilization of wrist joint and carpal bones, mobilization of median nerve. Following exercise can be performed to relieve pain of carpal tunnel syndrome. Taping for carpal tunnel syndrome. Frozen shoulder, also known as adhesive capsulitis, is a condition characterized by stiffness and pain in shoulder joint. Frozen shoulder occurs when the strong connective tissue surrounding the shoulder joint, called the shoulder joint capsule, become thick, stiff, and inflamed. Symptoms of frozen shoulder are divided into 3 stages. Number 1, freezing stage. In this stage, the shoulder becomes stiff and is painful to move. The pain slowly increases. It may worsen at night. Inability to move the shoulder increases. This stage lasts 6 weeks to 9 months. Number 2, frozen stage. In this stage, pain may lessen, but the shoulder remains stiff. This makes it more difficult to complete daily tasks and activities. This stage lasts 2 to 6 months. Number 3, thawing or recovery stage. In this stage, pain lessens, and ability to move the shoulder slowly improves. Full or near full recovery occurs as normal strength and motion return. The stage lasts 6 months to 2 years. Electrotherapy for frozen shoulder. Modalities, such as hot packs, can be applied before or during treatment. Moist heat used in conjunction with stretching can help to improve muscle extensibility and range of motion. The application of a TENS machine was shown reduce pain and increase range of motion. In painful or freezing stage, any activities that cause pain should be avoided and pain-free activities should be allowed. Range of motion exercises performed with low intensity and a short duration. A pulley may be used to assist range of motion and stretch. Core exercises include pendulum exercise, passive supine forward elevation, passive external rotation with the arm in approximately 40 degrees of abduction in the plane of the scapula, and active assisted range of motion in extension, horizontal adduction, and internal rotation. Passive joint mobilization of glenohumeral joint in grade 1 and 2. In second phase of frozen shoulder, more aggressive stretching exercises can be performed in order to improve range of motion. The patient should perform low load, prolonged stretches. Towel stretch, anterior, posterior and inferior shoulder capsular stretch, shoulder abduction stretch, finger walk or wall climbing exercises. Soft tissue mobilization. Passive joint mobilization of glenohumeral joint in grade 1, 2, 3 and 4 is recommended. During the second phase of treatment, movement with mobilization and end-range mobilizations are recommended. Mobilization with movement can also correct scapulohumeral rhythm significantly better than end-range mobilization. In third phase, continue all previous treatment option of phase 2. Exercise progressions including strengthening exercises to control and maintain increased range of movement. Physiotherapy is most effective during this thawing phase. Progressed primarily by increasing stretch frequency and duration, whilst maintaining the same intensity, as tolerated by the patient. The stretch can be held for longer periods and the sessions per day can be increased. I hope this video will be beneficial for you. Hit the subscribe button to watch more informative videos. In the next video, we will discuss about the positioning of a bedridden patient.